King's College. She's a professor of cognitive neuroscience there, and I don't think she needs a lot of introduction. She's held many very senior positions. She's a fellow of the British Academy, and she's had a string of awards and was rewarded with an MBE a few years back. Her contribution to autism has been really incredibly substantial. Although she's very modest, her work around what is neurodivergence and the whole idea of diversity and neurodivergence has really been central to her work. And her work is really now focused on how do you help the most marginalized, the most disadvantaged people who might have autism or be on the spectrum. Today, she's very kindly come to speak to us today as part of the Public Policy Global Health series. And public policy is really a major issue, and in a way, one doesn't always think of autism in terms of public policy, but I think more and more we recognize it's a major issue. The government have now commissioned a review of special educational needs and disability, which is ongoing at the moment. So this is really a moment, I think, to be thinking about these kinds of things. And Francesca very kindly agreed to say something about policy in relation to schools, policy in relation to older people as well. So Francesca, we're really absolutely delighted to have you. And if I could just say, many years ago, I went to see Francesca's supervisor to get some advice, Uta Frith, who was an absolute icon in the whole field of autism and related fields, to ask her for some advice about a grant I was putting in. And it was a complex issue, and she thought about it for a while, and they said, hang on, I've got a wonderful PhD student, I'll call her in. And it was Francesca, completely uninitiated, not knowing anything about what I had to ask her. She then gave me a 5-minute dissertation on what exactly I should do. I then realized it was going to be too difficult for me, and so I just dropped the idea. But it was really made me realize that some people just are at another level. Anyway, Francesca.
Thank you, Alan. Thank you very much. Thank you so much for inviting me. It's always such a pleasure to come back to Oxford and also to see some familiar and loved faces. So I get to talk to you about autism for maybe about 40, 45 minutes, and then I hope you'll have lots of questions and share your wisdom with me. So what I'm going to do is for anyone who doesn't know what autism is, I'll very briefly sketch that out, but then I'm going to talk mainly about how our notions, our ideas about autism have changed over the last maybe 3 decades. And I'll try and draw out some implications for policy, but I'm hoping that all of you will help me to do that as well, maybe during questions. So I'll start by just defining autism, and I'll go on to talk about 7 major changes in the autism concept and research, and then some conclusions. So autism is a neurodevelopmental condition with a strong genetic component, but it's really important in everything we're to talk about today that we remember that autism is a behavioral diagnosis. So there's no blood test or chromosome test for autism. A clinician decides that somebody's on the autism spectrum on the basis of a pattern of social and communication differences and difficulties and rigid and repetitive behaviors and interests, which in the current diagnostic criteria includes sensory sensitivities or differences in sensory response. So just on the basis of behavior. But underlying that behavior, we believe there are differences in thinking styles, which include an eye for detail, and sometimes a difficulty in putting those details together for the bigger picture. But the eye for detail can be very advantageous and lead to unusually good, strong skills in various areas. Also, those differences in social and communication functioning are underpinned, hypothetically, some of us think, by a difficulty in intuitively reading other minds or knowing what other people are thinking. And importantly, that's not a difficulty in emotional empathy. Emotional empathy can be absolutely intact and usually is, but the difficulty in knowing that you might think something or know something different from what I know. And that makes communication difficult, as you can imagine. And there are also sometimes difficulties in organizing and planning ahead and coping with change at the cognitive level. At the level of the brain, we know rather little, actually, about what characterizes the autistic way of processing the world. According to who you ask, people will say, well, we know it's to do with inhibition and excitation imbalance. And some people will say that's really getting us close to an answer, and others will say that doesn't tell me much more than that it's in the brain. We may be that we are making little progress in the brain because autism is very heterogeneous in terms of etiology, and I'll say something about that later on. But also our sample sizes and things tend to be too small. We have very few brain-banked brains for the sorts of investigations people would want to do. And genetically, we know that autism is strongly genetic. And the first twin studies that were done in the 70s by Professor Sir Michael Rutter, who was had the room next to me for many, many years at King's, proved for the first time that autism was not psychogenic, that you couldn't make your child autistic by being a refrigerator parent, and that was incredibly important. And that very early work with tiny samples has been replicated again and again to show very high heritability of autism. And again, I'll say something about what that heritability is about later. So sorry, I should have said, with the current definitions of autism, around 1% of children and adults will meet those criteria. The signs are present early in development, but there's a spectrum of manifestations, which means that many people come for first autism diagnosis late in life. And again, I'll be talking about aging later on. So to move on to some of the changes, I'm going to start with the change in the diagnostic conception, the diagnostic criteria, from a very narrow concept in the 1980s when I began in this field, where in the diagnostic manuals we still talked about infantile autism, and the DSM-3 criteria included things like pervasive lack of responsiveness to other people, gross deficits in language development. And if you think about most of the autistic people that perhaps you know, I don't think they would necessarily meet those criteria at all. And notice the other criteria I've listed, it's not exhaustive, but absence of delusions and hallucinations. So even in the 80s, people were still feeling the need to distinguish autism from schizophrenia, having at some points thought of autism as childhood schizophrenia. In the 80s, intellectual disability was common. Most of the children that I saw for my work were in special schools. Many of them had very little language, and many of them had intellectual disability. And we were fighting underdiagnosis. So it was clearly the case that we were seeing, for example, in the center that I helped in, a 15-year-old boy in a mainstream school, horribly bullied by his teachers, actually, as well as by the other pupils, who clearly was autistic, but nobody had picked it up. Now, in 2025, we talk about autism spectrum disorder, and DSM-5 from 2013 onwards has much wider criteria, including persistent deficits in social communication and social interaction across contexts, but they can be manifested in a range of ways. Restricted repetitive patterns of behavior, interests, and activities, including those sensory symptoms for the first time, even though autistic people and their families have been telling us about sensory differences for a long time. And the symptoms can be met currently or by history, but the current symptom profile must be impairing. And we're going to come back to that because that's very important in how you decide who warrants a diagnosis when you're talking about something basically dimensional. And very strikingly, it was only since 2013 that we were allowed to make more than one diagnosis on top of autism. So before that, you couldn't diagnose autism and anxiety, or autism and ADHD, but we know that those combinations are incredibly common. And again, I'll say more about that later. So now those identified as autistic with an intellectual disability are in the minority, and most autistic children will be in mainstream schools. The implications for research are that, sadly, intellectual disability and developmental language disorder, and their combination with autism are under-researched, underfunded, neglected topics in the research area. And a lot of us, particularly after COVID, moved to online data gathering, and that's not very friendly or helpful for individuals who are minimally verbal or not accessing online resources. But I'm hoping that new technologies could really open up this field. So whereas 10 years ago, even, it was hard to ask a child who couldn't talk to you very much about their experience or to test them in a research study that might help you to understand them and their needs better. Now we have all sorts of wearables that can measure physiological signals, eye tracking that's minimally invasive to see where a child is interested, where their attention automatically goes, and also things like mobile EEG that is much less invasive and difficult for a child. As far as I know, it's still difficult from physiological measures to know if a child or adult is excited in a positive way or is anxious and aroused in a negative way. But I'd be interested to hear about new technologies that might help us to do that, because that would be really, really helpful to know if when somebody is stimming in a particular way, so making a repetitive movement, is that a sign that they're needing to calm themselves down, or is it a sign that they're bored and they're needing to be more, more engaged, because then others around them could also adjust their behavior and environment to suit. Now, going along with that change from a narrow definition to a broader definition, autism has also gone from being a very rare condition. So when I was first learning about autism, 4 or 6 in 10,000, and as I mentioned, underdiagnosis, to today, I think a reasonable estimate of 1% of the population, but you will read estimates, for example, from the CDC in America of 1 in 36, which I find very difficult to process in my understanding of what autism is. And for the first time, and I don't think I would have said this even 5 years ago, people who are sensible and informed are beginning to question, is there overdiagnosis, or what would it mean for there to be overdiagnosis, or where do we put the boundaries to be optimally helpful to people. So a clinician, a colleague of mine, who is quite worried about giving the wrong label because it might mean you don't go searching for other things that would help. So something that we can discuss. What happened in between? Well, one of the things that happened in between was the DSM-4 came out in the mid-90s, and that introduced the new category of Asperger disorder for that part of the autism spectrum that has good intellectual functioning, good language, no language delay, but still has those social communication traits and rigid and repetitive traits. And I think one of the things that did was that when a child, maybe with a more classic, obvious form of autism, when a child in the family gets diagnosed as autistic, the family members read round. And once there were descriptions of Asperger's sort of part of the spectrum, it was quite likely that a grandfather, a mother, an aunt might say, oh, that's me, or that's granddad. Whereas before that, most of the descriptions of autism in the literature were of children typically, and children with really quite high support needs. So unlikely that relatives were going to sort of see themselves in that description. And the other thing that happened with the DSM-4 was that a new category was introduced that was meant to be a sort of safety net. And that's PDD-NOS, pervasive developmental disorder, not otherwise specified. That was meant to catch those very few people who just missed the criteria for a full autism diagnosis. But it turned out, when we were looking at the data to inform DSM-5, that the diagnosis of PDD-NOS had become much, much, much more common in the States than the autism diagnosis. So instead of being a little catch-all, it had become a huge rag bag where clinicians who weren't quite sure said, well, let's put you there. And that wasn't helpful for anyone. Now, there's been the suggestion, particularly in the States, that there's been a huge rise in the incidence of autism. And it's been referred to as an epidemic, which is clearly completely unacceptable language, because autism isn't a disease, and autistic people aren't a part of a disease. So the language which has been used sometimes in a well-meaning way in the sense they want to raise funds for more research or more provision, has not been helpful. And I think also, I, to be honest, distrust the data from the States, because the medical insurance, health insurance system there clearly drives what code is put on, and the code drives what money you get. So alongside the Autism Speaks controversial sort of money-raising, here's the huge rise in autism, I've also put in a graph for the same sort of period of state by state in America, the prevalence and the rise from 2002 to 2006. And I don't think that there's something in the water in Arizona that means that the rate has gone up a lot more than in Alabama. Much more likely the explanations are raised awareness, diagnostic criteria change, hopefully better provision in some places, and diagnostic substitution, because the rates of intellectual disability as a sole diagnosis have gone down, as the rates of autism as a diagnosis have gone up. But some more interesting data, perhaps less affected by the whole insurance system, comes from the UK, from Ginny Russell and her group in Exeter, where they looked at UK GP records over 20 years up to 2018. And I want to just alert you to the fact that this is showing percentage increase in autism diagnosis. So not the actual rates of autism diagnosis, but the percentage increase. And so if you start in, what would it be, 1998, with a very, very small number of individuals diagnosed for the first time over the age of 19, you can get a massive percentage increase, and that's what they found. So they stratified by age, and they're showing that the new rise is really in adult first diagnosis. And they also stratified by sex or gender, and they showed that the big rise in percentage increase is for women and girls. So Ginny Russell's interpretation of this is not that we're overdiagnosing, but that we're playing catch-up with individuals who were neglected from diagnosis historically. And you can imagine, because of the change in how the breadth of the diagnostic criteria, individuals who are now adults, but when they were children, the criteria were narrower, weren't diagnosed as children, but they do meet criteria now. So I'm going to carry on from this gender slide to say something about how that change from rare to common also needs to be reflected in recognizing the historical underdiagnosis of women and girls on the autism spectrum. So in the 1980s, people talked about a male-to-female ratio in autism of maybe 5:1, or if they were talking about Asperger's syndrome, they might say 10:1. And there was a notion that women were less likely to be autistic, but if they were autistic, they were more likely to also have intellectual disability. But all of these estimates were from individuals who had a diagnosis and were known to services. So either they were on special educational needs registers, or they were known to clinical services throughout age ranges, but people who had managed to get the diagnosis. Today, I think we would estimate maybe 3 males to every 1 female. Some people would say even a little bit less, or we should say 3 males to every 1 female would meet current criteria. And the ratio seems to be fairly similar across the range of intellectual ability, intellectual disability. And these estimates now are from good epidemiological studies where people go out and ascertain actively who would meet criteria for autism, not just who has managed to jump the hurdles to get the diagnosis already. And for me, that contrast in the male-to-female ratio, when we go from known to clinics and SEN to ascertained in the general population epidemiologically, suggests to me that historically we have missed thousands and thousands of women and girls who are on the autism spectrum. So what evidence do we have? Well, we know that at similar levels of symptom presentation, females are less likely to be diagnosed than males. Females are diagnosed later than males on average. And we see diagnostic overshadowing of more female stereotyped diagnoses. So in the eating disorders clinic at King's, they estimate that around 20 to 30% of the women who come in for an anorexia diagnosis or treatment actually meet criteria for autism on the standard diagnostic workup. You have to be careful because we know that at starvation weight, that affects social cognition. But the suggestion is that even when these women regain a healthy weight, they still have sufficient autistic traits to probably meet a diagnosis. And I'm happy to talk more about this in questions, but it's very interesting talking to those colleagues in eating disorders about the very different drivers that there can be for an eating disorder like anorexia in somebody who's autistic. But the danger is that if you're not in an expert center, the clinician sees the anorexia and they don't look beyond it to see this is anorexia in the context of autism. So that's the diagnostic overshadowing. We also know that the symptoms of autism can present a bit differently in some females, also, of course, in some males. So stereotypically, a teacher might think of autism social difficulties being aloof, but for some girls and boys, their autism social difficulties may show by being very clingy, by really having to be with that one friend all the time. And that may not look like our stereotype of autism. We also know that the special interests, the extreme interests that a lot of autistic people have, may have a more neurotypical focus, even though their intensity is still special and autistic. So if a clinician is talking to a 15-year-old boy and wondering if maybe autism is a good explanation for their strengths and difficulties, and he asks the boy, what are you interested in? And he says, oh, I'm interested in electricity pylons, and can I show you all my photographs of electricity pylons? The clinician will quite likely have a red flag, this could be autism. But if he says to a 15-year-old girl, what are you interested in? And she says, oh, Kate Winslet, the actress, or this boy band, or this breed of horses, the clinician may think, well, lots of girls are interested in those things. And unless he goes deeper and asks, well, tell me about that interest, and finds that this young woman collects facts about Kate Winslet but doesn't want to watch any of her films, or is fascinated by facts about one breed of pony, but any other kind of pony or horse is just completely boring to her, they're not going to realize that this is part of the pattern of this young woman's autism. We also carry with us a strong male stereotype around autism, and that biases our perception, so that when a teacher or a parent or clinician sees a socially awkward boy, autism as an explanation is quite high up in their consciousness. But for a socially awkward girl, social anxiety, shyness are the first things that they maybe think about. And I like these photos because the lining up of cars is such a prototypically could be autism sort of sign. But when we see the lining up of the cuddly toys, do we think autism, or do we think, oh, how sweet? He's going to play a lovely imaginative game of school with them. But that's just our lens that's coming in with our bias. And there's some good evidence that teachers, for example, find it harder to spot the autistic girl in the playground who's there on the edge of the friendship group, maybe not quite getting the joke quite as fast as the others, compared to the autistic boy who might be walking the perimeter of the playground while the other boys play football or something. And another aspect that makes it perhaps difficult for some people to recognize autism in women and girls, but also in a lot of men and boys as well, because none of these things are segregated by sex or gender. It's just that on average, we see more camouflaging and more atypical presentation among women and girls. But women and men tell us that they work very hard to look neurotypical. And it's often, sadly, because of bullying. So like this quote from NeuroRebel, I remember the decision to put on the mask the summer before I started at a new school. I was tired of being bullied. I studied movies to learn how to be a cool kid. And I've had autistic women tell me that when they were at school, they chose a girl in their class who was apparently popular. When they went on to work, they chose a woman in the workplace who seemed to be socially successful. And they copied everything about her: how she dressed, how she did her hair, how she did her makeup, how she walked, how she talked, what she talked about, just to try and not be ostracized or bullied for looking autistic or being different from those around her. We know that, unfortunately, autistic people tell us that this camouflaging and masking is exhausting and also can erode your sense of self. So there was a lovely 16-year-old girl that I remember talking to about her health crisis that she had, where she ended up, unfortunately, in hospital. But then she described how she came out of hospital and her friends all rallied around her. And while she was talking, I was thinking, that's lovely. That's really must have helped such a lot. And then she said, but of course, it's not me that they're friends with at all. It's the mask that I wear. They don't actually know who I am. So all that affection, all that genuine affection and love wasn't reaching her. And instead, she had this eroding sense of self. We also know that correlationally, camouflaging is associated with worse mental health. So with anxiety and depression in earlier childhood, with general and social anxiety in adulthood. Of course, that's correlation, not causation. It might be that if you're struggling with anxiety, you do more masking, but it certainly doesn't suggest that masking is at all easy for autistic people. And clearly, the onus should be on the neurotypical population to make it not necessary to mask, because there's nothing to fear from being authentic. Moving on to the third change in concept and research, from childhood to lifespan. So to put this in context, the UK has more pensioners than people under the age of 18. And yet, I'm going to show you in a moment, almost all autism research is with children. We've been so slow to realize that most autistic people are adults. And most autistic people, please God, will live most of their lives as adults. And yet all the attention is on children. We know that there are lots of adults coming for first diagnosis late in life, even in their 70s. And some of those stories are really tragic, of misunderstanding and blame and bullying. And although we don't talk about infantile autism anymore, I find very little awareness of autism among the colleagues that I speak to who work in old age psychiatry or old age health. So I often say, well, in your Parkinson's clinic or in your dementia clinic, do you see autistic people? And they typically say, no, I don't think so. So this is just to point you towards a useful paper by Liz O'Nions in collaboration with a group of us, where she looked at, again, GP records using upper and lower bound estimates. So I said 1 in 100 people are autistic. And she compared that to how many people are known to their GP services as having an autism diagnosis. And the bottom line is that over the age of 50, 9 out of 10 autistic adults are undiagnosed. This is our analysis of what research is getting published. And we looked from 1980 to 2021, and you can see the number of papers published in each year, and you can see it stratified by the age group they were studying. So childhood is the little dotted line, the highest one, then adolescence, adulthood. And older age in the big graph is so tiny that it doesn't even show up on that axis. So we have to have the inset axis with the tiny range of, in 2019, hurrah, there were 21 papers published on autism and looking at older adults, compared to, you can see the huge number of papers on children. It's important that we study aging and autism because we know that autistic adults, even younger adults, show higher rates of many, many physical and mental health conditions. These happen to be data from American health insurance records at a huge scale, where they could match non-autistic people for sex and age and compare the rates, and showed much higher rates, sadly, of suicide, depression, anxiety, also of a range of physical conditions. So the fourth change is from thinking of autism as something that is discrete, that is completely qualitatively different from anything else, to a more dimensional view of autism. And I think this really began historically when I mentioned that twin studies were the first important studies to give a clue to the etiology of autism. And at the same time that people were doing twin studies, they were also doing family studies to see whether other relatives in the family, not just an identical twin, if other relatives also had an autism diagnosis. And what they noticed was that some did, but many more had hints of autism. So subclinical traits of autism or parts of the autism picture. And they began to talk about the broad autism phenotype. They developed self-report and parent-report tools to measure broad autism phenotype traits. And over time, this has been extended to look at individual differences, even in people who aren't relatives of somebody with an autism diagnosis, to measure the degree of autistic traits in the general population. And in a moment, I'll just show you that the behavioral traits, if you ask people about behavioral traits of autism, are normally distributed, continuously distributed in the general population. Now, I know this isn't a popular notion, and there are some people in the autistic community who will say, you can't be a bit pregnant and you can't be a bit autistic. And I think the answer, can you be a bit autistic, probably depends on the level of description that you're using. It may be that cognitively, how the mind works, there is something qualitatively distinct and special about autism that isn't on a dimension. But behaviorally and genetically, it is dimensional. So behaviorally, with things like the autism spectrum quotient and other measures that are probably better, you can ask questions like, to what extent do you agree with this statement? I prefer to do things the same way over and over again. I often notice small sounds when others do not. Or how much do you disagree with this statement? I prefer to do things with others rather than on my own. And when you ask people questions like that, you get a range of scores. And you can see a combination of many, many studies in the graph here showing that on average, males score a bit higher than females on these kinds of measures. So a dimension at the behavioral level and a dimension at the genetic level. So the details of this don't matter there. It's just for me to tell you that we use twin modeling to look at to what extent the genetic influences on diagnosed autism overlap with the genetic influences on subclinical traits, those individual differences in autistic traits on something like the AQ, although we didn't use the AQ. And we found that largely they're the same genetic influences. And just while I've got a genetic moment, it's important to know that for most autistic people, the genetics of their autism is just like the genetics of their and our and everybody's height. So their autism is a product of hundreds and hundreds of common alleles that we all share, many of which we share, and each of those alleles, each of those genetic variants has a tiny, tiny effect. And it's the combination of all those many, many, many genetic differences, and maybe the combination of them as well as the number of them, that determines whether your degree of autistic traits is in the clinical range where you get a diagnosis or is subclinical or low. And it's only a very small number of people on the autism spectrum for whom there's a big genetic effect, something rare, something different from the genetics of everybody else in this room. So genetically, a dimensional approach is true for the vast majority. Now, the dimensional or trait-wise approach is really useful when we're facing underdiagnosis. So I've told you that 9 out of 10 adults over the age of 50 who are autistic are undiagnosed. We want to study aging and autism, but if we only study those who are diagnosed, we're going to get not only the tip of the iceberg, but very unrepresentative tip of the iceberg, because they've managed somehow to have a diagnosis. Maybe they had other adverse life circumstances that drove them to get a late diagnosis, but we're not going to get a true picture. So what Gavin Stewart and I have done is work with a very large online study of healthy aging called PROTECT, which has upward of 30,000 adults taking part. They go online, they fill out lots of questionnaires, they do cognitive tasks, and if they're feeling like it, they do them again the following year. And we were able to put in an autism trait measure and compare those individuals who said of themselves, when I was a child, I had difficulty socially. I sometimes didn't understand if people were joking or being sarcastic, and I liked to do things the same way, and I didn't like change. And as I am now as an adult, those things are also true of me. So it's not a perfect measure. When you get involved with a very large study, you never get to put in a 50-item measure, but it's worked well for us to collect information dimensionally about individuals who just aren't diagnosed. So I'm going to give you just one example, and I've taken a serious one, so for anybody who finds this upsetting, I apologize, because I want to convey to you how important it is to study autism in older age. So within PROTECT, we identified those older adults who had high autistic traits. They were around 1% of the sample, which is nice because that's where we would expect it to be. And we matched them with, for age and education and sex, with individuals who had low or no autistic traits. And Gavin's done all sorts of things. He's shown that mental health difficulties are very high in this trait-wise group, just like in diagnosed autistic adults. Trauma and adverse life events are very high in this group. This particular question was from a paper about self-harm and suicidality, and it asked the question, many people have thought that life is not worth living. Have you felt that way? And people could reply, yes, many times, and that's the darkest part of the bar, in either blue for the comparison or red for the autistic group, high autistic traits, I should say. Faded color for yes, once, and white for never. And I want you to remember before I show you the results, this is a volunteer sample. These are individuals who, like every volunteer sample, there are more women taking part, there are higher SES and higher education than the representative of the population. They've got the energy and the goodwill to go online and do a lot of testing. So these are not people who are representative of the whole population. They are people doing well. And I was completely shocked by this finding. So almost 60% of those with high autistic traits said that they had thought their life was not worth living many times, compared to, I think, about 18% of the comparison group. So in the past, we've had reviewers for our grants who've said, why is it important to study autism in old age? And I want to leave you in no doubt it's important to study autism in old age, even if we have to look at traits rather than diagnosis. The next change is from thinking about autism as one thing to thinking about it as many, and I mean that in two senses. In the first sense, we have a contrast from several decades ago when people were searching for the cause of autism. What is the cause of autism? And now I think people recognize that there are different etiological roots to autism and huge heterogeneity. And people sometimes talk about the autisms with an S to signify that. And some of the reasons why people think that we may not have made as much progress in understanding the neurobiology of autism is because we may be mixing in apples and oranges. So people are trying to search for ways to separate the apples from the oranges. I personally have slight pessimism about that, but I can talk about that during questions. And other people are studying those very rare big genetic events because they think it'll tell us about the final common pathway to autism. Again, I'm a bit skeptical. The other way in which I say autism maybe we shouldn't think of as one thing is that even at the individual level, I think we can think of autism as a compound of different pieces that come together to make that admixture that is very specially autism. So we've shown, again with twin modeling, that even in the same individual, the genetic influences on social communication traits and on rigid and repetitive non-social traits are largely non-overlapping. And going back to those family pedigrees, those family histories, you quite often find that there's a child diagnosed, and then there's a great aunt who was a bit of a hermit, a bit of a recluse, a bit difficult to get on with, but pretty flexible in her daily life. And then there's maybe a granddad who's an engineer, likes to eat the same thing every day for lunch, great eye for detail, socially fine. And you can see those two things coming together into that child to make the condition that we diagnose and define as autism by the combination. And when we've looked in the general population, although there is more of an overlap than by chance, if you look at who is in the extreme 5% for social difficulties, communication difficulties, being relatively rigid, the combination is above chance. But the biggest group are the 10% of children who have difficulties in just one area. And I think they're largely neglected. I don't think they necessarily are getting any diagnosis or recognition. And I won't say much about this, so I can talk about it in questions because I'm running out of time. But in the same way as we may not need to have one explanation for all the pieces of autism behaviorally, I think we also may not need to have one explanation for the different parts of the autistic mind. So I mentioned the detail focus, I mentioned difficulty reading other minds, and I mentioned executive problems or problems in planning. And again, we see those separate out. And we see them in the relatives as well, separate out. So the sixth change, and I've only got 7, so I'm nearly there, is from thinking of autism in isolation, pure autism, to recognizing that pure autism is actually very rare, and co-occurring challenges are the norm. So it's important to note that what makes life hard for most autistic people is not their autism, but the things that go with autism. And those range from epilepsy, intellectual disability, developmental language disorder, sleep, eating, gastrointestinal problems, discrimination, bullying, and trauma, and mental health, anxiety and depression in particular, and I've already mentioned the higher rate, tragically, of suicide. All of this means that we really need to work transdiagnostically, and whereas 30 years ago I was pushing for more autism-specific clinics, now I would push for more clinics that are not specific for autism, because you really need to understand the whole presentation. And this is just a graphic to remind you that 70 to 80% of children and adults on the autism spectrum meet criteria for an additional clinical condition, commonly anxiety and depression, sometimes ADHD, OCD, and so on. And the yellow graphic is to illustrate that most autistic people's experiences of healthcare and mental health care are negative. This is work by Miriam Martini, we collaborated with, to look at the wonderful and enormous Swedish health records. And in particular, Miriam is interested in autistic females, young autistic females. This is data from a huge sample of over 20,000 autistic young people tracked from age 16 to 25. And this is showing you psychiatric diagnoses that they've had during that time. And you can see that the diagnoses of anxiety, depression, Sleep disorders, self-harm are even higher in the autistic young women than in the autistic men, and many times compared to their non-autistic peers. And this one, I think, is even more shocking. So this is psychiatric hospitalization, and Miriam sums it up by as young as age 25 years, 21% of autistic females and 11% of autistic males, compared to less than 4% of non-autistic individuals, have been hospitalized for psychiatric difficulties. The reasons for high rates of mental health problems are many. We know that there's shared etiology, there's some shared genetic influences. We know that associated third factors like social disadvantage, most families where there's an autistic child, parents have often had to give up their employment or take lesser employment in order to advocate for their child, because it's so hard to get what children and adults deserve when they're on the autism spectrum. And there can also be phenotypic causal effects. So if we know that autistic people are more socially excluded and bullied, and we know that bullying is bad for everybody's mental health, if you have communication difficulties and it's hard for you to seek help, then your health, again, will suffer. And I want to briefly just tell you about a specific area of mental health that we've become very interested in and I think is under-recognized for autistic people. So the bus is here to remind me of the story that got me interested in PTSD and autism, which was from an autistic man who always took the same bus to work. And then one day there were roadworks and the bus had to take a detour, and the bus put him down in a part of London that he didn't know at all. And he's very anxious about which bits of London are safe and which aren't. So he was very scared that he was somewhere not safe. He was very scared he was going to lose his job because he didn't know how to get to work from where he was. And after that, not only would he not take that bus, he wouldn't take any bus. And when he walked past his old bus stop, he would start to re-experience the fear that he had had. And he had nightmares and flashbacks about that happening. Now, that isn't a life-threatening event in the DSM-5 diagnostic manual, but for him it was a traumatizing event. And so it made us think about the ways that autistic people might be more vulnerable to develop trauma-related ill health and ill mental health and or PTSD. And these include the fact that we know that autistic people are exposed to more negative life events, including bullying and assault. Experiencing a wider range of life events as being traumatic, like that bus example, having particular perceptual and cognitive processing styles, that eye for detail, for example, and sometimes having more avoidant coping strategy that may maintain those PTSD symptoms. So very briefly, I want to tell you about a study we did where we asked autistic people for whom something traumatic had happened, that they considered traumatic had happened. We asked them to tell us about that trauma and to complete a standardized questionnaire, the PCL-5, for trauma, PTSD-related symptoms. It's not a diagnosis, it's just a checklist, but it's a first step. And what we were really interested in was, does the type of trauma matter? So in DSM-5, criterion A says to get a PTSD diagnosis, you must have experienced, seen or been subject to a life-threatening event or threatened or actual physical or sexual assault. Nothing else counts. So here you can see the sorts of traumas that counted for that: physical abuse, sexual abuse. And of the autistic people who reported these kinds of traumas, around 45%, 43% passed cutoff on that PTSD checklist. And that's much, much higher than you would expect in the general population, where after a really negative life event, maybe around 9 or 10% would be passing cutoff on the symptoms. But more importantly, what about the atypical traumas that wouldn't be allowed in DSM-5? And these were things like being bullied, by being in horrible social situations, by even going through the healthcare system. And here you can see that exactly the same percentage, 43% of those who'd experienced these atypical traumas also passed cutoff on this standard PTSD questionnaire. So what seems to matter is if you find it traumatizing. And the last change is from thinking of autism as a developmental disorder to a neurodiversity and a neurodivergence perspective. And here you can see on the one side some of the old-fashioned, I would like to say, certainly old-fashioned in this country. There's still some countries where this very negative attitude to autism persists. but headlines like "How I Saved My Son from Autism" and these horrible adverts with these very, very negative views of autism. And then moving towards the autism self-advocacy movement, where autistic self-advocates have quite rightly said that it's no more appropriate to talk about curing autism than it was appropriate for psychiatrists not that long ago, a few decades ago, to talk about curing homosexuality. A different way of being that isn't deficient or wrong or need fixing. And this has been a big change from a purely medical model of disability that isolates the difficulty in the person to a social model of disability that identifies the disability as coming about through the lack of fit between the person and their environment and the expectations of a neurotypical world. I come back to some of these points. I don't want to run out of time, but the question of impairment and where, if we could make the world perfectly accommodating for autistic people, would there be no impairment? And what would we then call autism? Because we couldn't call it a disorder. Would it be just a way of being? But it's challenging because we want to recognize that autistic people need support in the world that we've presented them with, alongside recognizing that neurodivergence and being different from the majority neurotype is not a deficit. This has led to participatory research, stakeholder-led research, rather than the traditional scientist-led research. But it's still a challenge to make sure that all voices are heard, particularly those who maybe aren't speaking. So to finish up, challenges and opportunities. Scientifically, we have a fantastic opportunity with NHS routine health records that many countries don't have. We can build bigger data sets if we collaborate and incentivize open data. We need to have transdiagnostic working, and new technology should help us with this. And there are lots of neglected topics. Implications for practice and policy, just a couple of slides. So if we think about going from narrow to wide, we have a huge waiting lists for diagnosis now. Sorry, that's on the next point. The narrow to wide, you have to recognize there's huge heterogeneity. So to teach the right way to autistic children who may have very different ways of approaching education really needs evidence-based educational approaches. We wouldn't accept anything other than evidence-based medicine, but we don't seem to hold educational interventions to the same standard necessarily. Technology should be our friend for helping with inclusion, and we know that there are very, very high rates of known formal exclusions from school, but also informal. Just come and take your child home, would you? Don't bring him in today, we're going on a school trip. Don't bring him in today, Ofsted is coming. We really need to address that. From rare to common is reflected in those very, very long waiting lists for diagnosis, partly driven by the perception, and in many cases, the reality that unless you get that diagnosis, the school won't be given any extra money to help to put extra things in place for your child. But we should be needs-driven, not diagnosis-driven. And the childhood to lifespan perspective, remember, if you remember one thing, that out there, 9 out of 10 older autistic adults are undiagnosed. We need to support them. We need to improve awareness in adult services. And we need to educate our children with a lifespan view. They're going to live, hopefully, long and happy, healthy lives as adults. And the final implications of practice and policy, as we go from discrete to dimensional, the impairment criterion may change. So you might have a lot of autistic traits, and in some parts of your life, during some parts of your life, you might be impaired by the school system. At other parts of your life, you might find a job niche that is just right for you, and you're not impaired by autistic traits. In theory, you would begin going in and out of diagnosis because of that impairment criterion, but we don't treat it like that. But maybe we should be thinking about diagnostic threshold, but autistic identity. I don't know. I genuinely don't know. I want to hear people's answers and questions and ideas. I talked about isolated autism traits. From pure to complex, mental health is absolutely key. We need to change school and other settings, not the person. We'll improve anxiety by changing the setting. But we should also treat anxiety in all the ways we know work for neurotypical people, adapting them to work for autistic people. I've said that the DSM-5 criterion for trauma is too restrictive, and it's meaning that autistic people, thank heavens not in this country where we don't use DSM-5, but in the States and much of the world, will be denied help for PTSD because what traumatized them wasn't meeting that very narrow criterion. They're not the only group. from developmental disorder to neurodiversity, maintaining respect without losing support, and participatory education and policy models. And I'm just highlighting the House of Lords Committee is inviting contributions to its call for evidence as it reviews the Autism Act 2009. So one last highlight, thinking about inclusion, thinking about inclusive schools. Dr. Rebecca Wood, who's now in Glasgow, started a wonderful autistic school staff project where she asked the question, what is an inclusive school? And most schools will say, an inclusive school is where every pupil is welcomed. And she said, what about the staff? What about the staff? Are the neurodivergent staff welcome in this school? And she collected, and the resources there, one for the webinar is fantastic, and there's some free resources and some books. She talked to autistic school staff at all levels, head teachers, supply teachers, everybody, and she heard such interesting stories and such sad stories. From the inspiring, the teacher who says, when I told my pupils, some of whom are autistic, when I told their parents that I'm autistic, they saw both that their child could go somewhere and be happy and find a job that suited them, and also they felt I would understand their child. To the other extreme, where school staff were sometimes saying, I would never disclose my diagnosis in school because I've heard how the other members of staff talk about the autistic pupils. I don't feel safe. I would never disclose. So really different views that should teach us a lot about how we should go about making schools really inclusive. And I don't think I need my conclusions. They're all there for another time. I do want to thank you all for coming and thank Alan for inviting me and our funders and all our autistic and non-autistic participants and consultants and the members of my lovely lab group, past and present, and I'll go back for the resources. Thank you very much.
Thanks, Francesca. What a tour de force, really, really so clear. I'm sure there could be quite a lot of questions, and I think we can stretch on a bit to take some of them. Can I just ask just a quick question, which I think the answer maybe you may think is obvious. The elderly group, you implied why it may be that they may be so unhappy. Is it because of lack of care and lack of appropriate resources? Do you have any sense of that?
Well, sadly, I think if you asked autistic people at younger age groups too, whether they thought their life wasn't worth living, you'd also get those very stark results. The reason I highlighted was that they're a volunteer group who, their lives are going well enough that they've got the energy to do this, and they're still, having had a really hard life and suffering a lot of mental health difficulties. So it's not necessarily that mental health gets worse in old age, but that if we don't pay attention to autistic people in old age, then we're not serving them.
So with the right policies and, if necessary, treatment, that could be reversed, though?
Yes, yes.
Great, thank you. Victoria, there's a mic coming.
Thanks. Hello, I'm Victoria Whitford and I'm a psychiatrist here in Oxford. As part of my training, I had the privilege of doing 6 months of autism and ADHD assessments. And at the end of every assessment, no matter what the outcome was, I'd have a discussion with my consultant about how we'd done this lovely diagnosis and assessment and how there was no treatment. With literally hundreds, if not thousands of children on waiting lists, and the situation with adults being even worse. So I wondered if you could tell us a bit about the sorts of therapies that might be offered to children and adults with autism. And one that springs to mind for me is mentalization-based therapy, because this is a treatment that is used in adults and teenagers with communication difficulties, and I wonder how useful it could also be in autism. And I'm sorry, I should have said thank you so much. That was an absolutely fantastic talk.
Thank you. I'm afraid I don't know very much clinically. I'm not a clinician myself, so it'd be interesting to hear more about that mentalization approach. Clearly, the idea of treating autism is no longer how we approach neurodivergence. You treat the things that are making life hard. So you treat the anxiety, you treat the depression. For children, for all children, education is our biggest intervention, isn't it? And so getting education right. For children who are struggling to communicate, having some form of communication is absolutely key. So I think that I point to work by, say, Debbie Spain, who's adapted CBT and other approaches and has a very nice book about psychological therapies for autistic adults and how you can adjust those. And I know that there are individuals where I work who are very interested in dialectical behavior therapy. So I think that there are lots of things that can work, and it just depends where the child or adult is at and what they need, but it's not about treating the autism.
At the back.
Hi, thank you. I was going to ask, have there been any studies on whether the levels of depression, especially in adults, is the same before and after diagnosis? Because I would imagine post-diagnosis, it actually gives a plausible explanation for why you might have felt like you felt pre-diagnosis.
That's a very interesting question. So there have been studies looking at, with health records, looking at what diagnoses precede and which diagnoses survive a late autism diagnosis. And they tend to find things like that, particularly in women, a personality disorder diagnosis may precede a late autism diagnosis, but isn't maintained after the autism diagnosis. Whereas things like anxiety and depression, to my knowledge, do tend to be maintained. It's not a magic fix. Although I think what you're asking is a more interesting question. How does getting a diagnosis affect quality of life and well-being long-term? And certainly people describe the relatively short-term having an explanation for why they're different. And if you don't have an explanation, people, of course, find an explanation. So people who didn't know they were autistic have come up with the explanation or been given the explanation implicitly by others that they are broken or bad or stupid. And, of course, none of those things are true. And so the diagnosis can be a very important, both a mourning for what you missed if you'd had an earlier diagnosis, but also a reevaluation of your strengths and difficulties. And you're not alone. There are other people who have the same pattern of strengths and difficulties. But I haven't seen, it would be very interesting, I think, to do a more longitudinal study of the emotional process of coping with either an early diagnosis or a late diagnosis.
Eloise.
Thank you, Frankie, as always. I'm going to ask a slightly provocative question, which is based on the flexibility within the concept of autism that we've seen over decades. Kind of, why do we see a more rigid and less flexible concept of things like mainstream education and, bus routes when they change? Why do we have to have this rigid, will we drop you anywhere? We don't have this way of being flexible to meet needs. And how do we shift, if the kind of direction of change is to thinking, actually, there's nothing wrong with you, but it's what's around you that's making you anxious. How do we shift policy and the concepts of what we need to do systemically to meet a more diverse population? So the big question, but...
Yeah. It is a big question. I wish I knew. I think the rise in seeking diagnosis is part of reduced stigma. I think we have managed to reduce stigma, at least in this country, at least in some settings and places, so that people do feel comfortable to say, well, actually, I think I am on the autism spectrum. And maybe as more people think that way, there will be more pressure to say, well, actually, if 60% of my school class are neurodivergent in one way or another, maybe I can't stick to my rigid, what I thought worked for neurotypicals because I learned that 30 years ago. And there are some nice examples of good practice. There are schools, mainstream schools, where they will say, we don't wait for the diagnosis. If it looks like autism, we do what works for autism, because we know what works for autism helps everybody. And that's the truth. It's having more clear indication for when there'll be unexpected changes, having quiet spaces people can go to so they don't have to be in a noisy playground. If they can't cope, then go and stack books in the library. All of those things, those little tiny things, make a big difference. And the studies we've done qualitatively around things like school exclusion, and it's not rocket science, it's neurodivergent kids don't feel they belong because they're given negative messages by sometimes peers, sometimes teachers, sometimes both. They can't cope with the sensory overload, and they're not being given any slack, so they're not being able to go and have a bit of quiet time. And the system is too rigid, so even things like, well, they have to wear that uniform that's got that scratchy, horrible thing that they can't wear, actually tiny things that you could change, it wouldn't put anyone out, it wouldn't even cost any money. So I think good examples and more awareness, but I agree it's hard to know how we're going to really change the dial, and especially when schools have less money than they've ever had before. So.
In the back row, we'll just take 2 or 3 more questions and that's it. Thank you.
Hi, thank you so much for your talk. I'm just going to out myself as a member of the government's advisory group on inclusive mainstream schools. We're meeting tomorrow, so this is perfectly timed. So much of what you're saying is resonating with the things we're kicking around, but we are under so much pressure from lobby groups to pursue an approach that entrenches diagnostic thinking, particularly around ADHD, dyslexia and autism. And we have worries about that. You mentioned DLD, which is an area that we're thinking hard about. So I'm wondering, is there a taxonomy of need that we can pull on? Because this feels like the missing puzzle piece that cuts underneath these diagnostic categories and enables that more strategic response. So I'm just interested in your thoughts to that, and so glad so much of this resonates with the things we're thinking about.
Good. I think what I've been thinking about a lot recently, and you can see it in sort of half-formed throughout, is this impairment criterion. Because the notion that most individual differences lie on a continuum does seem to be generally true. I mean, it's the direction of travel for almost everything. ADHD, autism, dyslexia, everything seems to be more or less on a continuum. And then the only way you can decide who needs services or who needs diagnosis is because your traits are impairing you or distressing you, or whatever we're going to call that thing where it flips over from being just individual differences, you're different from me, to, yes, I'm different, but I'm different in a way that I'm struggling with and I need help. But the impairment criterion is really difficult to operationalize for a number of complicated reasons. So, but I think that's the key part. I think that's the key part somehow. And that's why I say needs-based, because need reflects the impairment or the struggle, whereas you can be very, very autistic, but if you find the right niche, you won't be struggling, or you won't be struggling, maybe to that degree.
I'm going to just take a few from you. I could always forget to ask. There are a lot of people online, just to give a few questions. So what are your thoughts about the concept of virtual autism?
Oh, I don't think I know what that is. Does anyone help me in the room? Virtual autism?
It takes a while to get people online, so I'll just
let them
go. What has helped the improved diagnosis rates in females? Asked somebody.
What has helped? I think increased awareness. Vicky Milner here has done some really good work that's raised awareness and writing about what the barriers are. And realizing some of the things I mentioned about how you can meet the same symptom criteria, but in ways that we weren't stereotypically looking for.
And perhaps just one more from...
Oh, you know what virtual autism is? Oh, good.
May arise from excessive screen exposure in early childhood.
Yes. I thought that was going to be different. I thought at the end it was going to be that can arise from extreme maltreatment or adverse life events. And there is an interesting question about, for clinicians, how they distinguish between a child who's, because of the difficult things they've experienced, is having difficulty connecting and so on, communicating. That's a different question. I don't think that screens can make you autistic, but it's not something I've studied, I'll say. But thank you for finding out what it was.
So someone's asked to share the slides. There are quite a lot of other questions, but I think we probably need to start. There was one more question, I think. Just, no.
There's one over here.
One, okay. Go for it.
Hi, thank you. Yusuf, a trainee clinical psychologist here. I was wondering, you started off talking about the behavioral phenotyping and that having been the legacy upon which autism has developed, both clinically and in research terms. And I'm wondering about the integrity of this as a label, whether it's something that is even worth pursuing at all, and wondering whether we are approaching the paradigmatic boundaries of this term. And also thinking about like Kathy Lord's work around promoting labels such as profound autism to kind of address these stopgaps of needs.
So it's an interesting question. It's sort of important to remember that while in some cases it can be difficult to diagnose autism or to know, where would we put the boundaries, actually sort of prototypical autism or autism in the middle, as it were, is incredibly well agreed on. It's one of the best agreed between clinicians diagnosis. So there clearly is something very characteristic that we recognize and for which we know much of what helps in terms of education, the educational approaches that help autistic children, quite well, well-trodden paths. So we don't know nothing. It's at the edges, and this question of if you have a lot of autistic traits but they're not impairing you, or you have a lot of autistic traits but you're getting by, but is that because you're camouflaging, so actually the amount of effort it involves should be considered impairing, and that's where it gets sort of messy. But there's a lot of autism that is absolutely, you read Canner's descriptions, you can go into an autism special school and see children that you can absolutely see Canner's description in. So it's absolutely, autism exists, I think. I mean, there's no question about that. The fact that our understanding of it and the concept of it is changing, I think, isn't surprising. It's a relatively recent diagnosis, even though, of course, autistic people have always been with us. But it's a good question to always return to.
I think we'll probably have to leave it there. Firstly, I just want to say thank you, but also to say that Francesca's written a whole range of books, and they're in the blurb over here. But particularly one to mention most recently is Neurodivergent Inclusive Schools. And I would recommend that one particularly to you. But just to say, when we invited you, I thought, well, policy, I hope this is going to be policy. And you've absolutely convinced me there can be no bigger policy than this. It's so important, and you've made such a case that unless we sort some of the policy and some of the kind of attitudinal aspects of society out, we're not going to go a lot further with this. But thank you very much for such an absolutely fantastic and such a clear description of so many issues and so thought-provoking, and your answers to your questions, which I think are just so clear and so helpful. And we'll hopefully have you back in the not too distant future.
I hope so. Thank you very much.